Hi guys, my name is Jessica Farrell. I'm a clinical pharmacist at Albany Med Division of Rheumatology and professor at Albany College of Pharmacy and Health Sciences. I'm also a member of the RhAPP board. So today we have Journal Club, and the article that we're going to be talking about is a recent article that was published in Rheumatology and Therapy in March of 24 by Fleischmann and colleagues. And the title of the article was Long-Term Efficacy and Safety Following Switch Between Upadacitinib and Adalimumab in Patients with Rheumatoid Arthritis, a 5-year data from the Select Compare study. So why are we talking about this article? So many of us are very familiar with the treat to target guidelines and strategies. They are to make sure that you are adjusting therapy if there's been no improvement within 3 months. So for our RA patients who are not having improvement at that 3-month marker, we need to switch gears. Then if they are not at their complete target by 6 months, so say they had some response and they are not at their target by 6 months, then we need to switch gears also. So what are our options for switching gears? So the ACR guidelines, the old guidelines, used to say to stay within the same mechanism of action. So if you had a patient on a TNF, it wasn't unreasonable to try another TNF. The updated guidelines, however, do say that to choose a different mechanism of action as opposed to staying with the same one. So that's a little bit of a shift in practice over the last 5 to 10 years. When I first started in rheumatology, it was very common for us to, start with a TNF inhibitor and stay with a TNF inhibitor, sometimes 1, 2, 3, before switching out of the class. But updated data and updated recommendations say that it is recommended to switch from one class to another, over staying with the same one. So let's get back to the study. So the study is important because it gives us switch data. And I call it switch data because I find it very helpful to see studies that will go from one class to another or one drug to another, and then back and forth, which is really helpful to see if patients maintain a response, respond better, one does better or the other. So this study its objective was to look at the long-term efficacy and safety of upadacitinib and adalimumab through 228 weeks, following an immediate switch to an alternative therapy with a different mechanism in patients with RA who were not at goal with their initial randomized therapy in that Select Compare study, which is a phase 3 study. So patients were enrolled. They were enrolled to either upadacitinib 15 once daily or adalimumab 40 milligrams every other week. So if they did not achieve their target goal, they were switched to the alternative. So if they were in the upadacitinib group, they were switched then to adalimumab. And if they started in the adalimumab group, then they were switched to the upadacitinib med. So we looked at the data. So this was at 26 weeks. So then what the study looked at was efficacy was evaluated through the 228 weeks post-switch. So the first part of the study was 26 weeks. So then there was that switch at 26 weeks, and then data was evaluated essentially 5 years out. And the efficacy measures that they looked at were Clinical Disease Activity Index, or CDI, with low disease activity, or remission. So they looked at both, actually. So CDI with low disease activity, CDI with remission. And then they also looked at ACR scores. They also looked at some secondary endpoints and change in baseline. I'm going to talk primarily about the CDI though, just to keep it concise. They also looked at safety and assessed treatment emergent adverse events through 264 weeks. So what did they find? The patients initially randomized to patients that were initially randomized to upadacitinib and adalimumab. So there was, of the patients randomized to upadacitinib, 38.7% switched to adalimumab. And then of the patients randomized to adalimumab initially, 48.6% of those patients switched to UPA. So it might be easier if I say UPA and ADA, but we'll see. So the clinically relevant improvements in all the efficacy measures were observed through 228 weeks post-switch, and they were generally similar between the groups. So I'll go through a couple of those numbers and try to help kind of compare and contrast. So if we look at the CDAI remission, so this is clinical disease activity, validated tool showing remission. So this was achieved by 32.7% of the upadacitinib patients, and then 28.6% of the adalimumab patients who were initial non-responders. And then 27.5% of the upadacitinib and 27.3% of the adalimumabs who were incomplete responders. So you have those two subsets. So we have remission in non-responders and remission in incomplete responders. And those are very similar. So that's promising. Those are promising numbers. With a CDAI of low disease activity, so CDAI of remission is pretty challenging, so that's why you saw those lower numbers. But CDAI of low disease activity is a reasonable assessment, and that was achieved in 76.9% of the upadacitinib group, and then 72.9% in the adalimumab, who were initial non-responders, and then 72.5% of the upadacitinib, and 72.7% in the adalimumab of those incomplete responders. So as you can see, those numbers are very similar. So when we're switching from a JAK inhibitor to a TNF inhibitor or TNF inhibitor to a JAK inhibitor, we're able to see that we're able to achieve these efficacy measures and pretty high numbers too from the CDAI of low disease activity. In terms of safety, so again, I've mentioned this many times when I presented that safety is so important, and one of the things that me as a pharmacist on the team end up talking a lot to patients about. So with our JAK inhibitors and our TNF inhibitors, more so the JAK inhibitors, herpes zoster infections are something that we want to look at. Also anemias and CPK elevations. Those were the three things. So herpes zoster infection, lymphopenia, and CPK elevations were more frequent in the upadacitinib group compared to ADA, but they were similar to what we've seen in previous studies. So it's not like a new safety signal. So what do I do with this information? Well, I think that this is really helpful data to, bring to my practice, because I get this question a lot, and the patients ask this. So, the well-versed patients who are know what TNF inhibitors are, know that there are multiple options for them, know that there are new therapies. They ask, should I stay in this class? Should I stay with a TNF inhibitor and try another? Or should we switch out? The providers come to me and ask me the same thing, kind of weighing risk versus benefit, especially for the patients who've had some response. So, those are those patients that we are, worried about. But I think this is great data to show that we can switch back and forth and get good outcomes. And it just makes me more confident with helping the providers make those decisions. So that is all I have for today. If you want more information, more journal clubs, more med reviews, quick little snippets, head to the RhAPP app or the RhAPP website. We also hope that we will see you at our annual conference, and have a great day.